Joining me on this episode of the Dr. Beau Show, and I'm Dr. Beau, I'm always here, is Dr. Ivo Waerlop. Waerlop. I should ask him how to pronounce his last name better, but I think he'll forgive me on that. Dr. Ivo of the Gait Guys. Dr. Sean Allen was supposed to join us, but he couldn't make it. So Dr. Ivo definitely held up the Gait Guys pillar very well. I mean, I could read for well over an hour on Dr. Ivo's bio. He is a certified chiropractic neurologist, certified rehabilitation, or let's actually read this. Board certified chiropractic neurologist, chiropractic rehabilitation physician, and certified chiropractic sports physician. A lot of post-grad stuff. Besides that, of course, like I said, he is part of the Gait Guys, which they have had a blog and a podcast for a very long time, a stout YouTube channel with tons of information, which I'll be linking to in the show notes. On top of that, I mean, Dr. Ivo has done everything from build orthotics, work with patients and athletes in the realm of more traditional chiropractic to becoming completely myopic on foot and lower extremity, then getting into building his own orthotics and then starting an orthotics lab to where he is now with their clinic, Summit Chiropractic, where their tagline, let's see here, is rehabilitate, rejuvenate, and regenerate. It looks pretty legit, and it's a more human, holistic focused practice. So he's kind of come full circle from this, typical chiropractic. He tells the story of how he got into chiropractic and his first peaking interest of his own experience, all the way to this like holistic approach to treating a human. But most people would think of him as one of the Gait Guys, and that's what we get into. We talk about, why Gait, when do we change Gait? Does the nuance of specific structural pathoanatomic variance within the gait cycle and within movement overall, how much does that matter? We talk about, gait algorithms, all these things, the stories we tell ourselves with human movement, how much that matters as far as pain outcomes. I mean, there's a ton of this podcast. And then we get into some fun stuff at the end there too. I hope you guys enjoy, and here we go. Yeah, but I have a ton of questions for you, and this is where we'll dive in. I think I first remember reading the Gait Guys blog when I was sitting in like Tri 3 at Logan in St. Louis, and I should have been listening to whatever was being taught in the class, but I was reading, I was like, man. And I still remember it was something about climbing. What was it? There's a picture of a baby, and it was climbing, and it had DNS in it, and it was a bunch of different stuff. And I was like, man, this is like kind of things I'm interested, but it goes way off the deep end. So I want to kind of go beyond your bio and first of all ask, how did you get into this field? Because a lot of us have our own sob story or, our own inner detective. Like, how did you get into the field of physical therapy?
Okay. It's I got into chiropractic with a long time ago. I had ear infections as a kid, and I'd been to the doctor millions of times, hospital, ER, all of that stuff. And my parents had heard about this guy who was a chiropractor, and Dr. Walter Heaney. I don't even know if he's still alive these days. But anyway, they called this guy up at, 4:30 in the morning. And they drove me to his house, which was a few towns over. And this guy greeted us. And back then, this was, late 60s. People practiced out of their house. So this guy meets us in his nightshirt, no kidding, with a nightcap. And Dr. Heaney had this enormous, huge beard. And he brought me in, and his living room was a waiting room. And then like one of the side rooms was a treatment room. And he put me down on a table, and I was having an asthma attack and ear infection, and couldn't breathe. And he adjusted me, and I could breathe instantaneously. And at that point, it was kind of like, wow, there's definitely something to this. So that's left a lasting impression on me. And then, I went to college. I wasn't sure if what I exactly wanted to do. I was pretty sure it was going to be in the medical field. So I had worked for a physical therapist for a while. A guy named Repshire up in Albany. I went to SUNY Albany, and it was a lot of fun, but I realized, wow, if I was a chiro, I could probably do a whole lot more. Just as far as at the time, this is back in the, early 80s, just as far as being able to do diagnostics, that kind of stuff. So I started school. I applied to a bunch of schools. NYCC was my first choice because I lived in New York at the time, and it was on the island. So at the time, it was an easy choice for me to make, although I applied a bunch of different places. And then that's where my education started. And then there I got introduced to people like Barry Wyke, who I actually got to see speak, and of course, Ted Carrick, and a bunch of other professors who sort of molded me into where I am today.
So kind of interesting to take the spin. And for anybody that's listening that's not in our career or, a colleague, there is a body of evidence of chiropractic adjustments and that relationship to affecting bronchospasm, bronchodilation with asthma. That's actually one of the things that's been studied quite a bit. So anybody that's out there is like, oh man, this just started on the curing the blind person with the adjustment. Like that is a very, substantiated source, but that takes us like, no pun intended, like 9 steps further. Like how'd you go from obviously a kid getting an adjustment for an asthma attack ear infection, going through school, and then you're ending up today in this completely mechanistic gait foot driven world that seems so far away from that initial, first contact with chiropractic? Like what would that evolution look like?
So when I went to chiropractic school, I was always sort of one of the nonconformists. I was heavily into anatomy and neurology. That's always been my interest, always kind of science-based stuff. I was maybe fortunately or unfortunately, I'm not sure, never really much of a philosophical kind of guy. And I had a lot of, great professors and stuff, but I was more interested in the nuts and bolts and show me a paper, sort of like Thomas, show me the injuries. And if you couldn't do that, it really didn't exist in my world. So I got very involved with, at the time, motion palpation, neurology and that kind of stuff, and really didn't have much interest in gait or anything like that. When I graduated school, I practiced in New York, backing up a little bit. So when I was at NYCC, I was very interested in anatomy. So I ended up working as a student TA in the anatomy lab. And I loved it. I did all the prosections, that kind of stuff. This was my world, except for smelling like cadaverine most of the time. It was really good. And I probably killed way too many brain cells by sniffing that stuff for too many years. Then when I was graduating, they offered me a job at the lab. So I took it, of course, because I love anatomy. And did that and was there for quite a while, and then got involved in some sports stuff. Ultimately practiced in New York for a short time and moved to Massachusetts. And at that time, a good friend of mine, Dr. Paul Chili, who practices in upstate New York, and Patrice Carroll, who I've known from school, and we used to hang out and do a lot of stuff together, were really into this guy named Ted Carrick. So I was like, oh, and he just happened to be teaching the neuro program in Boston. So I went through the neuro program. And then I went through the neuro program again, and then I went through it again. And then I started teaching the neuro program for a group called ACES out of New York. And that sort of got me started on that whole platform. So my first 9 years of practice was very neuro-based and Cybex driven as far as that kind of stuff in my clinic. Pretty much, rehab, all kinds of injuries. I practiced in Gloucester, Mass, and we saw a wide variety of different things. Then I moved to Colorado in '96 and was working in a clinic. I took 9 months off, skied, did a lot of fun stuff, and then went through a divorce, and then kind of had to get it back together and do something. So went back into active practice, and I had 2 podorthists in my practice. Peter Morin, who's still a good friend, and another guy named Sean Eno, who you may have heard us talk about on the podcasts and stuff. And I was getting people like 80% better, and they were taking people a step further. And all they were doing was sticking this thing in their shoe. And I just had to know more about what was going on. So I started pretty much inviting myself to hang out with these guys pretty much all the time since they worked in the office that I was in, and became very good friends, spent a lot of time in their labs. And then that sort of formed a lot of what was going on with learning foot and gait mechanics. Then I left that practice. I started my own practice, and I actually had Sean Eno, who you may know, used to rent space from me. So I would spend a ton of time with Sean. And he taught me an insurmountable amount of information about orthotics, lower extremity biomechanics, and footwear. And then, being in there, I got involved with Soul Supports at the time, who you may know, Ed Glazer, head of that company. I don't know what's going on with them, but became involved with those guys because they had a very biomechanical approach to what was going on. And somewhere in there, I got introduced to Tom Michaud's work with the original stuff. And I got Michaud's first book, the black one, the foot orthoses book. And I just ate it up. I mean, I read it all the time. I carried it around with me and really got into it and actually got to know Tom. He practiced in Newton, Mass. I was in Gloucester. And it just kind of took off from there. And for a long time, I started just manipulating people's nervous systems as well as their biomechanics just using their feet. I did very little manipulation of like spines and stuff like that. I mean, I guess we always do some because we're chiropractors, but I really became involved with that and found that that was really the foundation. And then along the way, we, Sean Eno, myself, and Sean Allen thought it would be a good idea to open up an orthotic lab because Sean was already building our stuff. So we had a group back then that used to lecture and teach called PCG, Pedorthic Consulting Group. And the first time I'll never forget, I met Sean Allen. It was really funny. We were teaching a gig, I think at National. I don't remember exactly where it was, but I show up and I'm from Colorado and I'm really cool in my jeans and my shirt and everything. And this guy shows up in a 3-piece suit, and fancy shoes. And I'm like, oh my God, who is this tightwad? Anyway, Dr. Allen stood up and started speaking and I was just totally blown away. And we've been friends ever since. And then down the road, we realized that the three of us were really good friends, but we sucked as business partners. So Sean Eno took over the lab and Sean Allen and I kind of went off and started doing more of the educational stuff. But yeah, that's it. I mean, there's not many people that are feed geeks out there, which is kind of a cool thing. We meet some and, we kind of geek out about that kind of stuff and talk about it. But I don't think anybody out there, and correct me if I'm wrong, because you're probably better read than I am on some of this stuff, but I don't know anybody that's really approaching stuff the way that we do, as far as looking at both the sort of the ortho neuro approach, to what's going on with a lot of gait. You'll find a lot of companies that are doing like F scans and things like that, where they're looking purely at just the mechanics, and you got other, camps that are looking purely at the neurology. And we try to marry the two together and, kind of look more at movement and how's that occurring globally. And then how can you affect that with, the feet, lower extremity, obviously not just with orthotics, but with exercise and different types. I'm very heavily into needling therapy. I do lots and lots of that. Anyway, probably went on too long, but
no, not at all. And that gives us a lot of jumping off points, but maybe this is a terrible question, which sets us up for a terrible answer. So I'll place the blame on me, but what does your practice look like now? Because you can say it's this, neuro-ortho approach, a neurocentric approach, focused, down or, bottom up, but like, what's that look like? So if a patient comes in, like what is differentiating you? Because somebody could very easily, right, say, well, we specialize in, running and we really focus on feet. And then we look at your practice and we're like, oh, holy cow, totally different ballgame. Like, what are the differentiators? What are some of the influences? Like what, can you dive into that? Like, again, that may be a terrible question. I don't know.
No question is ever terrible. They say that, wisdom comes from making good decisions and making good decisions comes from making bad choices. So we can kind of jump off from there. My practice looks like, first of all, I practice in Western Colorado or west of Denver, about 100 miles up in the mountains. We're at about 9,000 feet, our office. We're on the 3rd floor, so we're actually a little more higher than 9,000 feet. Most of my practice is people that live in Summit County, but I do have people that come from all over to see us because of, what we do with feet and lower extremity stuff. It's very varied. We don't pigeonhole ourselves into anything. We bill ourselves as a healthcare office, not a chiropractic office. So we obviously do chiropractic, we do acupuncture, but I mean, we do nutrition, we do blood work, we do diagnostic ultrasound, we do PRP, we do stem cell, we do rehab, we build orthotics, we do gait analysis, bike fit. We kind of do a lot of things. So my morning might look like a breech person coming in and we're flipping a breech baby, followed by somebody with Crohn's disease, followed by an MCL or ACL kind of injury, a plantar plate injury, a broken clavicle. It's very, very varied. My approach probably isn't that much different than your approach or anybody else's. We do a pretty thorough history, focus in on what's kind of bothering the patient so we can, maybe treat that right away, and then work on the bigger issues, as far as other things that are going on, like what's driving that dystonia, or, who's driving the bus, as we like to say in the office a lot. So it's probably not that much different. I'm fortunate that I practice with some pretty brilliant people. I always believe that if you surround yourself with brilliant people, you'll appear brilliant. You don't necessarily have to be brilliant. But it's more of a global approach. Obviously, it's very gait heavy. I have a lot of interns and docs that'll come up and spend a day, a couple days, a week, a month. We've had interns that come for whole semesters that hang out and do stuff. And happy to say that a lot of our interns have gone out. Some of them never do gait stuff because we just, they got a little too much of it here. And other of them really got into that. So I wouldn't say that I'm really better or, we're different. We are the metapractors, I guess you'd call it, in our area. I've got two other docs in my office, Dr. John Ashalter, who's been a business partner of mine for about 10, 12 years now. And then he's heavily into ART. And then we just hired Dr. Nick Hedges, who I believe that's how we got together here. Mm-hmm. Nick came on with us a little over a year ago. He's a big climber, big into DNS. Nick has actually lectured for me at some of my dry needling seminars and stuff like that. Super bright guy. We're always bouncing ideas off of one another. We always have more than one set of eyes on what's going on, and we're constantly, referring within the practice, like to different, we all have our strengths and our weaknesses and stuff like that. So it's really probably not that much, if it's not a traditional, like, bang down the high spots kind of practice, or let's just stick them on therapy. I mean, we do use therapies, but it's more active type of care, like I think a lot of people do. I mean, that's what you have to do. And most of our stuff is closed chain based. So like open chain exercises can be okay for building strength, but not necessarily for building, proprioception and things like that.
Well, we're going to put a bookmark on what you just said right there. We'll come back to that. So I think anybody that's sufficiently, had some patients under their belt, is looking out for what's best for the patient, has to have somewhat of a metapractor approach, if that's what we want to call it, right? That, you're not going to be able to help everybody. You have to have a multitude of tools yourself, but also then a team around you. And then, it goes outside of you for great referrals. And I think that's anybody, even you being one of the Gait Guys that specializes in, gait, lower extremity, but still you're like, you got to take care of a human, right? And it doesn't just stop their feet. I'm going to go back, and I know I kind of asked this, but I'm going to dig in on this. Why gait? Like, why for you do you think gait is somewhat at the center? Because I'm assuming, maybe wrongly, that it's largely at the center of exam and maybe functional outcome, that you're looking at changes, on the front end and back into that. Why is that centric to you? Is there, a theory of why it's important, or is it just interesting? And that's the only lead into that.
Probably a little bit of both. I think it's super important the way people move, not just gait, but how they kind of do everything. If you have 2 feet and you walk and you need to get someplace, you have to, how you get from point A to point B and what that looks like tells me a lot about your nervous system and what's going on. And that might tell me why you have chronic rotator cuff tendonitis or bicipital tendonitis or whatever else happens to be going on. So it's not just, gait, but I would say it's definitely lower kinetic chain focused. And we look at, stacking. We talk about it's just a bunch of building blocks. And if something's not going on right down below, as you come up the chain, it's going to cause changes. And we'll show people things in the office about like how a foot problem can contribute to a shoulder problem or something along those lines. So, it's important, and that fact that people, number one, obviously feel better, but also to move better. And, the way people move, it might not look the way that it's supposed to look in the textbook, but that might be normal for them. I mean, we've treated lots of people and taught people they never told could run again that have a triple arthrodesis of the ankle just to run differently. It's like, well, you're just going to run different than the other kids. It doesn't matter. You're out there doing what you need to be doing. So, why that? I think that the feet are really neglected area of clinical practice in school. And I had great education. I had a lot of really awesome professors at NYCC. I was fortunate to have people that are either no longer alive or aren't with the school anymore. But there was never really a focus on that lower extremity biomechanics and what's going on. And I think that because I saw such a big change personally, as well as in my practice, with people by doing things with their feet that, it's part of every exam. I mean, all the stuff that we do here, it's skiing now. It'll be mountain biking in about 2 months, and then it's running and mountain biking all summer. All of those sports require input from the lower chain, and if something is having a problem down there, you've got some kind of abnormality with a forefoot to rear foot relationship, or a lack of range of motion, or inappropriate neural feedback coming to a certain area, then that's going to strongly impact what else goes on. Plus, you got to think about it. 31 articulations in the feet. That's a lot of mechanoreception, and a lot of receptors. And if you look at the sensory homunculus, you've got a huge amount of cortical representation for the feet, as well as, obviously the lips, the face, genitals, things like that. But the feet are huge. And if you're neglecting that area, because the spine is so poor in mechanoreceptor density, except for the upper cervical spine, and even muscle spindle density, when you look at the studies and stuff, the feet are just so much important. And when you start to look at how the afferent stimulus is coming up and it's going through the nervous system and stuff, cerebellar afferentation is really where it's about. Information going in, getting coordinated with your cerebellum, which coordinates with your vestibular system, which coordinates with your basal ganglia, which helps us to stay upright in the gravitational plane. When those things, that input is better, then you're going to function better. So that's probably why. Yeah.
Which makes sense. I'm going to play devil's advocate on stuff, not to be, hey, this is where I live, but I want to kind of open up a can. When we talk about this interaction with the gravitational field and, the block on top of the block, and, going through some of your podcasts, like there's blog, like the loads are going to go somewhere. This idea of these stories that we write, right? And again, just playing devil's advocate of, hey, lack of, great toe extension can lead to, excessive, forefoot motion. And then here we go up the chain, we write the story, which makes sense to us and maybe actually be happening. Like you can watch it and be like, look, other people can confirm that bias. How much do you let your bias get confirmed versus also saying that may not be the case, right? Like we can see it happening, but then maybe pain isn't being derived from that mechanical story I'm telling myself. How much do you have to play in that middle ground? Because I go through that same thought process. So I'm just curious, not to go into the pain neuroscience camp, but where do we stop sometimes and say, man, there are people out there with far different mechanics. And again, another blog article, you talk about when do you change these things, and this endless conversation of like, are the mechanics a driver? Is pain in a subset of its own? Where do we make change and where do we implement? And I have multiple questions lined up for this. So I'm like watering at the mouth, just seeing where this goes.
Okay. I have tried to have an open mind for a lot of things. I make clinical leaps of faith, just like I'm sure you do and everybody else does in practice. I can remember sitting in Dr. Carrick's lectures, 20 years ago, and having him say something, and you're like, there's no way. I had a joke with Dr. Chili that we would talk about, like, Dr. Carrick would be talking about something. It's in JMPT was the big journal when I was going through school. There were very few things that were really focusing on manual medicine, and that was one. So we used to call it TMPT, Ted's manipulative. And son of a gun, like 3 years later, 5 years later, a paper would come out and it was exactly what he was saying. And Dr. Carrick for me was a huge influence because he would make a lot of these leaps and connections. And I would say a lot of them were true, not all of them. And we try to do the same thing. We probably operate on the edge a lot as far as that goes. We try to be science-based. A lot of pain, as you're aware, there is peripheral cause for pain, especially when you have damage to receptors and stuff, but a lot of it's cortical. You look at like Frank Pareca's work and stuff like that. So we're always looking back, and the bottom line is they're feeling better, they're moving better. And that's not always based on a paper, an article, a psychometric instrument like a VAS or something like that. It's there. If I waited to base everything on, a fact or a paper came out on it, or every single thing had a totally objective measure of outcome, I wouldn't be able to treat people as far as that goes. So I do play back and forth. I am always listening. Dr. Hedges is never slow to bring things to my attention about like, well, I just read this paper on this. And then we can get into a conversation regarding that, which is good. So it's not all pain-based. I think that, and we've talked about this a lot, and it sounds like you've listened to a lot of our stuff. The longer I practice, the more I realize that it may not be like, well, yeah, you got a torn plantar plate, but that's like, what drove that and how did that get there? And a lot of this stuff that we're seeing are like cortical lesions or physiological lesions. So they're not boo-boos that we can see on an MRI, a CT scan, an X-ray, PET scan, something like that. And maybe on PET scans, because we don't PET scan every patient. But the point is they're physiological issues. And when you address them, they get better. So it's just like, and you do needling, you do dry needling, you do acupuncture. How does that really work? Are we really resetting spindle gain? Because I've seen a number of articles that support that and a number of things that present it, and both of them have very compelling arguments from a CNF perspective. So I think that it's in your head, like a lot of things are. Not that everybody's nuts or something like that goes to, one of our offices, but the point is you have these abnormal patterns with millions of neurological connections that are occurring throughout the body. And, Ted always talked about the central integrated state. In other words, the state of the neurons, which are driving, one primary pathway or something like that. And if you change that central integrated state, you change everything else and all the connections that goes with. So I think that if you're addressing the patient, more holistically, you're adjusting them, you're talking to them, your office smells nice, there's good visuals, all of that stuff plays into the patient getting better. And is it something that I'm doing, or is it all smoke and mirrors? I don't know. I think placebo has an extremely strong effect on what can go on. You'll read books like The Biology of Belief and things like that. It really makes you wonder. It's like, well, maybe I'm really not doing anything. And it's just the fact that I sat down and I talked with this person for 40 minutes and understood their problem and gave them a couple simple things to do that they weren't doing, that they got better. And maybe it had nothing to do with me.
And I've liked the term lately of belief effects instead of placebo effects, because the placebo in terms, right? When you say that immediately seems to have a negative connotation, even though it has nothing but the exact opposite of negative in the name. So something that you said in there are these clinical leaps of faith. More for maybe the students listening, I'm not saying that was going to sound really crass the way I was going to ask. I was going to say, what gives you the right to have these what allows you to have these leaps of faith? What's gotten you there? Obviously it's a comfort level, but what backed up that comfort level? I mean, I could have guessed, right? Years of experience, anecdotal, outcomes, but like, what do you think fuels that? Because not everybody's doing that.
Not everybody's willing to take the risk.
Right. So what gets you there?
Sometimes, and you see this in your practice too, you're the last stop. Like, they've seen everybody, they've done everything, they've had all the surgeries, they've taken all the meds, and nobody has done, what you're doing, or, taken it to that next level, or done something a little fringy or something like that with them. So I don't know. I mean, I think I guess I have big brass ones sometimes, but I'll try it, and I'll do things, and I'll tell people like, look, I don't know if this is going to work, but let's give this a try. Nobody has done this particular thing. So I don't know if it's really a right. I mean, we try to be very informed with what we're doing with people. We try to have it make sense to us as well as them clinically. We're always willing to try to provide evidence for what we're doing. It's like, well, we've treated this many people for this long, and we've gotten this effect. So theoretically, that should work, for you, but it may not. So I wouldn't really say it's a right or anything like that. Part of it, like you said, when I got out of school, I knew everything. I'm sure, nobody else did, but I definitely did. And I've learned a ton over the years, and I've learned a lot by making a lot of mistakes. And that's, unfortunately, I'm not a good listener. I'm a do like I do, not like I do like I say, not like I do guy. But those mistakes have taught me a lot with people. And thank God, I mean, I've got wonderful patients, wonderful students that I've been teaching for years and years. I taught anatomy and physiology at the local college for like 10 or 12 years here. And I see a lot of those people. I've watched them go from being, graduates newly from high school to some of them are physicians now, nurses, biomechanists, PTs, podorthists. It's good. But I think a big part of it is willing to take that risk. And I think that a lot of you think of the old time chiropractors, that were practicing in the back room, and doing all this stuff. And some of that stuff was probably kind of sketch, that they were doing. But some of these guys were willing to take that chance and to take that leap. And, I saw Dr. Carrick do that a lot as far as with things, or at least in my mind, it was that way. And maybe he, knew it all along. I'm not sure. But I don't know, it kind of gave me the confidence to kind of do some of that. And I'm wrong a lot. We do not have, 100% outcomes in our clinic, which are wonderful all the time. I mean, a lot of people fail at care and don't do great. So it's more of if people are willing and we can give this a shot, and sometimes it works out, and sometimes it doesn't.
Well, and I'll add just a very short 2 cents on that. I tell all of our, whether it's an undergraduate, intern, and extern, that owning the bare bones of science, right? The things that we think are just requisite to get to the good stuff, right? Anatomy, physiology, physics, biomechanics, owning that stuff is what I really think opens up that door of like, you're always critically thinking about the piece of research you read, the thing that you just got taught at the last seminar, what is happening in front of you with the patient. And if you don't own those things, there's no way that you can critically analyze them. Right? If you're like, I kind of understand physiology, but I'm just going to go with this, what I think's happening, rather than like, well, no, that doesn't make sense, right? Dry needling, right? What's actually happening? We can experience the subjective patient outcomes and the objective changes we see, but what actually happened, right? And if you keep questioning that based on the principles that we learned earlier, that's where pretty soon you start to make assumptions based off of time, anecdotal input, and things like that. And that's what you have to do, because that precedes any type of study, like you said with Dr. Carrick. And I think we need more people that have that freedom, but aren't just going after it without critically analyzing things. And I think that happens quite often, that it's like, I have a hunch, I'm not going to analyze, I'm just going to do, and the outcomes speak for themselves. Well, just like you said, your office may smell nice, you're a super nice person, you get great outcomes. That doesn't mean it's a new methodology or a new paradigm shift. So I really appreciate I think you're an extremely brilliant person, and everybody in your practice is, and that breeds this kind of environment to allow our entire profession to grow, not just your office, right? Because now you're speaking about the things that are happening, and we learn when we get together. And I've always said that, and maybe you have a different perspective on this, when I go to chiropractic, physical therapy seminars, continuing ed, and if you've ever been to an MD conference, they're very different. When a MD is up there speaking at a conference, they are getting questions constantly. And these are high level questions that are questioning the science that's being basically purported to everybody and, then examined by the crowd. You go to a chiropractic conference, there are questions. Most of them are confirming questions. Somebody already knows what they want to hear when they ask a question. A lot of it's just like, we get spoon fed, we listen to it, we're like, oh, it's cool. That's kind of what I wish we would see more of, is this like critical thinking, analysis of what's happening, get, people together and like not pick people apart, but like, let's think, right? Not let's just like have more doers, like more thinkers that help us do better. So I had nowhere to go on questions on that, just a tangent of like, I think you're doing great things in your clinic and with what you guys put out via numerous things, which we're going to talk about later. So one thing I want to get into on Gait and taking these, clinical leaps of faith is, if somebody, say a clinician, a student, somebody's already doing this, they're wanting to use Gait or are using Gait. What's something that you see people maybe getting wrong? And I hate to use even the term wrong, right? That maybe it's not even in the analysis portion, like the extrapolations they take, how they're using Gait analysis, maybe corrections, like what's something that, maybe it's a pet peeve of yours within like the Gait world at large. Does that question make sense?
Yeah, I don't really know if I have any pet peeves. The biggest thing I see is you have to understand what normal, or what, I don't want to say normal, expected, ideal should look like before you start looking at pathology and figuring out what that is. That's probably the hugest thing that we see. In other words, who's driving the bus? I can't tell you how many knee problems we see that people are addressing the knee, and it's south of the knee, and they have a forefoot varus or an internal torsion or something like that. So I think that understanding what's supposed to happen when, and that's why I talk a lot, in the seminars that I teach and stuff like that, about what muscles are acting when and what's supposed to happen and what you should be seeing and what the basic ranges of motion of each joint should look like. And then after that, extrapolating that to potentially what's going on with your client. I mean, you see lots of people that have plenty of ankle dorsiflexion on the table, but when you put them in a gait situation or walking situation, they don't utilize that. So we have the expression in the office. It's like, well, you're not weak, you're lazy. So we just need to teach you to not be lazy anymore to get to that. So not really pet peeves. I think the biggest thing that's overlooked, and of course, this is one of my one of the things that I like to talk about a lot, but are torsions and versions. And I think that that's overlooked tremendously. Working with the ski industry a great deal here in Colorado, I see lots of people that do custom boot fitting and stuff locally, and people that have had, the fit guarantee and have gone back, no kidding, and spent hours and hours and hours having them grind out boots and stuff like that when all they needed was a valgus post because they had internal torsion and their fifth was rubbing up against the side of the boot, or they're trying to stick a curvy foot in a straight lasted boot, stuff like that. So I think that that's probably one of the most underlooked areas. And even in the podiatric and in the orthopedic realm, it's not talked about a ton. When I go to seminars, and I'm at places, and even locally when I'm talking with some of the podiatrists and stuff, they're just not looking at that stuff, and in my opinion, that's important.
Why do you think that is, especially podiatry? Like, you think that would be, if you're only dealing with this much of the human body, you think everything would be encompassing, examination and care. Any hunches on why?
I don't think it's taught in school. I didn't learn it in school, really, the first time I ever learned about internal tibial torsion was, from Shawnee No, and then screwing up on a patient and sticking them in a person that had ITT, and we put a nice big fat arch with a deep heel cup on them, and they started to develop knee pain. And all of a sudden now that gets me to start thinking and looking. And again, that's one of those learning from experience. Experience comes from making bad choices and doing that. So I just don't think it's taught. If you go out, so first of all, there's huge disparity with torsions versus versions. So versions are normal. Torsions are more than 2 standard deviations outside of normal. But if you look online and use Dr. Google or one of those search engines or something, they're misused and interchanged all the time. And even in the scientific literature, when you're looking at it to truly talk about, they're saying they have femoral retroversion. It's like, well, no, they actually have femoral retrotorsion because, their femoral head angle is less than 8 degrees. So this is a true torsion situation, not a version situation. But it doesn't matter. The fact that, something like that is going to limit internal rotation of the hip, and that's going to have its consequences that are going to occur both south of the hip and north of the hip. And looking at that, I think, is important. And I don't think that that's stressed enough. And maybe it is in other camps. I listen to a lot of podcasts. I read a lot, and I don't see it a lot out there, and I haven't heard it a lot. And that's probably one of the reasons we talk about it a lot, is because, in my opinion, I've seen lots and lots of patellofemoral disorders that, yeah, dude, you're in a motion, control shoe and you've got ITT. It's like, that's why your knees suck when you're going downhill. It's like, let's do this. Let's increase the motion of your first ray. Maybe let's, grind your insole or something like that and help you out a little bit until you can earn your way back into this shoe.
So we were talking in our office the other day of this upcoming podcast, and we do a lot of gait analysis, a lot of running gait analysis, and the level of nuance, I would call you guys the master of nuance, right? With gait, when I've listened to you speak or write, it goes deep, right? And I think that's kind of your forte. How would you weigh in on people that, not that they don't want to have that level of nuance within their clinical examination and treatment, but is it necessary? I guess is my question, right? Obviously you're going to I've run into numerous cases where I wasn't even going after the knee and medial knee pain, but then you end up realizing like, oh, this is a structural issue that I'm dealing with, that then I have to address that. Like function isn't going to dictate pain outcomes. Like how important do you think that is for people to address that up front and not miss those? Because again, why isn't that taught more often? Why isn't it talked about more often when it's actually a fairly easy thing to examine for, right? It's not that difficult.
It's super easy to examine for. It's one of the first things, we teach when, we're working with groups and we're doing a gait seminar or something like that. One, I don't know why it's not taught more. Two, I think that problems left unchecked for a long period of time lead to other problems, even if they're not symptomatic. So there's a lot of mechanical faults that we'll see, whether they're mechanical, neurological, physiological things that we'll see that are going on that can lead to problems later on. Now, can I show you a paper that says that people with ITT have premature degeneration of the knee? No, but I can show you lots of x-rays of patients that I've seen that have had that issue, and they've had it worked on by podiatrists and surgery and lateral releases and all this other stuff that still aren't better, that you do something really simple with them and all of a sudden they're feeling better. I think that if you look at that stuff up front, it creates less work later. So backing up a little bit, when I first got into doing orthotic therapy, and we call it therapy because theoretically the prescription should change over time. You shouldn't it's not like set and forget. It's like, all right, you're doing your exercise, and if you're getting stronger and you're getting better and your mechanics are improving, then I should be able to pull correction out of that device and eventually, hopefully, get you to the point where you don't need it or you need minimal, kind of support in your shoe. When I was, manipulating pretty much everybody, and all I did was foot stuff, that's pretty much for probably a 3 to 5 year focus. I think you just become so myopic at looking at these things, and you don't, you don't pay attention to the other factors that are going on as far as other things that you might be missing. Like, all right, well, they're always supinating on the left side, but why? Well, they have an anatomical short on that side. And that's something that, typically, not always, because you always have the fake out, but that you would see. But anyway, I would manipulate everybody's, feet pretty much with orthotics. I mean, I pretty much did everything. You have low back pain, we were going to fix that with orthotics. And it was really good and also a really bad time in my life because, one, I learned a ton about orthotics, and I was always changing and mixing and playing with all this stuff. And it was good because I learned how to do all that stuff. But when I was all done, I realized I really spent way too much time doing stuff that I probably didn't even really need to do. As far as that goes, or I was a little too overzealous or a little too overconfident, taking some of those clinical leaps we talked about before. But thankfully, I've got a very understanding and forgiving patient population, and people would continue to work with me, and we got it straightened out. And now I realize, having done all of that, the more work you do up front, and anybody you talk to that custom makes orthotics, and not I'm talking like, stamping them out, I'm talking a guy that's grinding in the lab and everything like that, the more upfront work you do, the less work you're going to have to do later. And the more maintenance you have to do on a device or whatever you're doing, creating for that patient later on, is costing you time and then ultimately money. So if you can do a great job and catch all that stuff up front and think about, you're already thinking, it's like, all right, we're going to do this. And if this doesn't work, this is the next, situation that we're going to, impose on the foot, whether that be some kind of posting or a softening of the arch or deepening of the heel cup or whatever. The more of that work you do up front and you realize what's coming possibly down the pike, I think that it saves you time and also saves the patient a lot of problems later on.
Well, and we just 2 weekends ago, Dr. Courtney Conley, Dr. Rich Olm, Dr. Brett Winchester, we had the R2P symposium. And I mean, via that, obviously, Courtney, extremely foot centric in treatment and approach, but it was interesting because everybody's weighing in. It was a lower extremity symposium. And at one point, the question came up that had to come up, that they're dealing with a person from the crowd that has back pain. They all basically take their own diagnostic and treatment approach. And then it was like, well, what would we actually treat first if it was just one person in the room, not 3 clinicians? And that was what, I asked the question. I was like, well, where would you start? Right. Cause you all do the same stuff, right? Even though she's foot centric and you're DNS, like we're all good. And I think that's, like you said, you had that myopic era. I really think it's what phase you're in as a clinician. And I know people may be like, what do you mean? But like, I think the further you get into clinical practice, and I'm not, nearly as experienced as you, but I think you realize that like you're not like your myopic opportunities go away and you get better at becoming myopic on that patient, if that makes sense. That, you know, nobody could answer in that symposium, would I have started at the back or is it a gait thing? It was like chicken or egg. Don't know. But that leads me to my question here. When, and maybe your answer is just like, that's what I do every time. I always don't know. I'm going to be honest. I don't know when do you try to change gait without changing function first? And I'll clarify that. So if somebody doesn't have great hip internal rotation, right, non-structural, and we improve that, could I have done better by still working on some gait? Let's say it's a runner, some gait thing with that, or up front or first. And then I wouldn't, you know what I mean? I'm always playing this game of, would the hip have changed had I changed gait? I think gait changes based off function. Like, what's your weigh in on that? Because I think that's like the magical question, right? That gait is this thumbprint of movement. It's completely bio-individual, right? It's a outward facing facade of the central nervous system, but like, what's the input, right? Is it these functional changes? Is it coaching gait different? Is it coaching it via orthotic? Like, what are we doing?
I think that, treating, we'll usually address the area of chief complaint first, even if it's symptomatic care, before we're going to change anything else. Mostly because that's why they're there. If somebody's got a low back problem and they come in and I'm looking at them and I know it's coming from their feet, I can't just say, well, we have to do this and not touch your back. It's just not, you're a nut and they're going to leave and Waerlop, he's a wing nut, forget it, don't bother going there. So I think that we do that and we do obviously appropriate things, being a chiropractor and, I'm big into manipulation. Obviously we will do that. We do a ton of exercise. We talk a lot about, diet. We talk a lot about lifestyle. What do you do for a living? How do you move? You drive a heavy machine operator at the dump, and you've got a crappy neck because, you twist your head to the left or you're running a snowcat or whatever. I think you have to address that. And then gait comes in at a later time because, it's not real obvious to the person. Although I might be looking at the way they're moving and I might say something like, and notice that, they have a crossover or something. It's like, you know what, when you go out for a walk, just put your arms at your sides rather than across your body. Just give it a try. And to do that, as opposed to people that come in, and we get people that come in from all over for gait analysis. Like that's why they're here. So obviously we're going to be gait centric on that visit because that's where they came from, Canada or Ireland or wherever they're coming from. For us to do that. But then again, I don't think you can separate the two. Gait's just part of movement and it's just another way that they move. And everybody moves the way they do because of their neurology and what's going on. So, as far as does that fix it? I don't know. Like I said, I don't know if I really fix anything. I facilitate people. I give them different types of input. And sometimes that makes them feel better. Sometimes it doesn't. There's a lot of people that look great when you look at their gait, and they still have symptoms. Mm-hmm. So, fixing how it looks doesn't necessarily fix the problem. And then as far as, treating the area, like I teach dry needling quite a bit. And I can't tell you how many times like we've needled. Now, when I was teaching up in Canada a lot, back before COVID and all that, these are all PTs mostly that I'm teaching up there. And it's a really great environment to be. I don't know if you've spent much time with Canadians or up in that area. But they don't care like if you're a chiropractor or a garbage man or what you do. You have a knowledge and a skill that they want to learn. And it's very, very open and everybody's very level. Even the MD people and stuff that I've worked with up there, everybody's on the same level playing field. But getting back, and I was getting off the subject there, we'll do something. It's like, all right, so rather than do a MOB or something on this, this SI joint that's not moving, let's just go down and, they'll have trigger points in their proneus longus. It's like, let's just needle the proneus longus and let's see what happens. And we've seen huge changes. Now, was that because I suggested that? And it was just the power of suggestion and it improved and neurologically that did something. Did I actually do something when I was needling that? Or was it some other factor? And I can't answer that question.
That's what keeps you getting better, is having that question in your own head all the time, right? About what you're doing, what caused what. And that's what I love, however true they are, the further they get away from the actual point of actual happening. But like Carol Levitt, you know, in his first like clinical outings, not letting people talk at all, right? That they came in, he didn't want to know subjective input, subjective output, right? Like I got the change I wanted. I wanted to go after what I wanted. And that's, you know, how he learned so fast. But if we flip the, you know, when do you change gait question from pathology to performance, what are the parameters around that? And we could take this walking or running, because this is the most common question I get, right? When you work with runners or somebody that, you know, when do you make a prophylactic change or a necessary change or at all? Like, how do we answer that question on the performance end of things?
We see a lot of people that come in for performance enhancement as far as that goes. So with those individuals, we will look for the big stuff first. You know, do they have an actual leg length discrepancy? Do they have some sort of torsion? What are their global ranges of motion like? Can they get their first ray down? You know, do they have adequate calcaneal eversion? Is there enough hip extension? And address some of those issues and see if that makes a change in their times. As far as that goes, or whatever sport they happen to be in. You know, they can run pain-free. I mean, you know, we'll see. The Leadville 100 occurs out here, which you've probably heard about. It's a huge 100-mile foot race. And people come from all over the world to come to this race. So we'll have somebody come in 2 weeks before the race to train to get acclimated to the altitude with a raging Achilles tendonitis and want to be able to complete the race, you know? So at that point, it's triage. You know, you're doing, it's like, look, this isn't fixing anything. This is going to help you to get through so you can finish, but you really need to address this. Yeah, I don't know. It's a tough situation.
Yeah. And that's, you know, I hate to, you know, be Stu McGill about it when you tell people, but it really is, it depends, right? Like timeframes, goals, a lot of things, right? Like,
well, and do they believe that what you're going to do is going to make them better? So I did a study a number of years ago looking at orthotic changes in cyclists and power output. And it never got published as far as that, other than like internally. But the bottom line was orthotics, and there's a lot of studies out there, and you've probably read, you know, some of the stuff. Well, it improves VO2 max and all this other stuff. Bottom line is, inexperienced cyclists, okay, orthotic, placing a, you know, Russian-based orthotic into the shoe after, you know, an exam and everything, no other parameters really addressed, did increase power output. Okay, approximately 5% to up to 10%. And it decreased heart rate, okay, beats per minute by 1 to 2 beats per minute consistently. Inexperienced riders, inexperienced people, not as much as far as that goes. So, you know, what does that mean? Was it the fact that they were in my office and they spent an hour there and we were going through and we had them hooked up to all kinds of stuff and we're pulling lactate and doing all this, and that effect had that much on them that they did better and they tried harder? Or did the orthotic really make that much of a difference? And I can't tell you the answer. I can tell you that there's a whole, you know, psychological component to a lot of what every doctor does, not just chiropractors or PTs or whatever that come in. And if you interface or click or whatever word you want to use with that client better, and you understand them better, or their perception is that you understand them better, then generally they're going to do better. You know, whether you actually make, I mean, we'll have people that are feeling great and their ranges of motion get worse. Right. So it's kind of like, all right, good, as far as that you're feeling better and that your times are better, but you're, you know, globally, physiologically, you're not better. But maybe that isn't the parameter we should be looking at.
Right. And it, honestly, if it's performance, those functional, you know, parameters may not be the best outcomes anyways, right?
Right.
Because if I'm becoming a better distance runner, I'm probably moving worse from our eyes as a clinician if I'm looking at bare bones top level movement. Kind of in that you put in on the questionnaire that one of your kind of areas of work or future work is creating these gait analysis algorithms. And I think where we've been heading with talking about when do we change gait, you know, what are we doing with gait? Is that specific to is that software or algorithms within your clinic? Can you explain that a little bit?
So probably clinic algorithms to start, you know, like where do we start exam wise and everything? And then how does that translate to what we're seeing on an actual gait analysis, you know, of what we're doing with the patient? So They have internal tibial torsion. They have lack of first ray things. They came in. Please call them. They have lack of first ray plantar flexion or whatever. How does that specifically play in, to what's going on?
Yeah. So what's the goal with those? To help other clinicians outside your clinic to,
okay. Yeah. Not like really to sell it or anything like that. It's not like a profit motive kind of thing. We want people to be educated. And, Sean and I do what we do because, we're pretty geeky and we just love what we do. We obviously, if you've looked at our history over the last 10 years, we're not making a fortune at this. We're not retired in the Caribbean or something like that. It's nothing like that. We just started like a year and a half ago doing Patreon stuff just so we could like spend more time doing some of this stuff because we enjoy this. The more people, young people or younger people like yourself, like Nick, like stuff like that are out there that are looking for tools to help them get going, at least we can help them get in the right direction. Not that what we're necessarily doing is the right way, but this is the way we did it and we got these results. So I'm a firm believer if somebody already invented it, I don't need to reinvent the wheel. I'm going to follow your framework. I'm going to do what you did to get that same success. And then once I've mastered that, I'm going to tweak it and I'm going to make it mine and do it my way. As far as that goes, which is a huge change from when I first started practice, where I was going to do it my way. And that was the way it was going to be. And that was okay, but it only gets you so far.
It sounds familiar. Yeah, my wife would agree. But that also kind of helps you though, because you also learn your own folly of like living on an island, right? Like this is how it's going to be done. You set yourself up for fast failure and you learn really fast. And then you realize like, oh, you learn faster with others, right? And you can fail just as fast and then have a sounding board too. And I love having more clinicians than just my wife and I now, right? Because it's the same thing. Like, I get more ideas. They get more ideas. Sometimes you feel like a failure and you're like, oh, it's not that bad because 3 other people failed just like I did. Some questions that I ask everybody on here. This could go anyway. It doesn't even have to be in clinical practice. What is something that you thought to be true or you held true for a long time that has completely got flipped on its head? Whether that was by research, findings, again, doesn't have to even be clinical. But what's something that you're just like, man, I came to an epiphany or this just flipped and I've completely 180'd on that? Yeah, these are always thinkers. I need to have music play after I ask these.
Yeah, you probably have to do something. Wow, something that's totally flipped. I think, probably one of the biggest things is the perception of, how you see yourself versus how everybody else sees you, as far as that goes. And then being able to accept, what you're seeing in the mirror on a daily basis and for what it really is, not for what you want it to be or what you wish it was or what you thought it was, and seeing that reality. And I think that's probably one of the biggest things.
All right. See, and again, it didn't have to be clinical. Great. What is something that you think you're just like, I know it's true?
Oh, no, there's one other one. Hang on. We got to go back for a second.
Yeah, go for it. Yeah.
So, and you're going to laugh. You're going to like, really? You were an anatomist and like you made that mistake. But, for the longest time, up until just a few years ago, I always thought that the peroneus longus was a dorsiflexor and everter, not a plantar flexor. And I taught it that way. I've got recordings and video of me teaching it that way for years. And after a seminar, I had taught one, and the gal that does a lot of work for me up in Canada kind of took me aside, and she's like, she's showing me this anatomy program. We're looking at it. I'm like, oh man, I've had that wrong for so long. So it's just kind of a dumb little thing, but it was just sort of like, it was one of those moments like, wow, I really, because I can't tell you how many times I said that, yeah, it was pretty funny. Always
learning, right? I'm
always learning. That's always good.
Yeah. Let's flip that question. So what's something that you're just like, I know it's true and there's no evidence, right? Like it just hasn't been, it's one of those Carrick things. We kind of talked about this, right? That you've been doing it, you get awesome results. Doesn't even have to be clinical, right? You're just like, I know this is true. There's no body of evidence. There's nothing out there. Is there anything that's just like burning, in your brain all the time like that?
as far as that I believe to be true, but I don't have any evidence to prove that it's true.
Or that something you wish would be studied further, or, it doesn't even have to be in your clinical practice. Something you're like, man, I just have a hunch or a strong feeling or, personal evidence that this is the case. We just
Two things.
Okay.
One, the existence of God.
Yeah.
Okay. And the second was the power of meditation. Just as far as I have seen in my own life, huge differences just from starting to be able to do that, from how I was before and how I am now, and things like that. And just there's things and events that have happened in my life that there's no other explanation, chance, nothing that could have explained it other than divine intervention. So those are the two things.
I'm curious.
And I don't have any evidence to prove that.
Yeah, impossible evidence, maybe on one, maybe some on the other. But I'm curious, how long ago were those changes in your life take place?
Recent, like within the last couple of years.
Let's dive into meditation. What spurred you? I know it's become very popular, but what spurred you to take up a meditation practice?
Insomnia.
Oh, all right.
Yeah. For a year and a half.
What is your specific meditation practice? Any school of thought,
I'm not a big guided meditation guy. I do box breathing. Mm-hmm. I've got some affirmation stuff that I stay on a daily basis. And I guess time with, prayer and reflection and Thanksgiving at the same time. It's about anywhere from 20 to 40 minutes a day as far as that. And if I miss a day, I notice. And if I miss 2 days, everybody else notices. So it's made me a lot mellower.
So has it helped with the insomnia?
Oh, huge. Yeah. Yeah.
Oh, so I'm just curious, I dive it into this. Why not? Is that in the morning? Is it at night?
It's every morning.
Okay.
I'm a big linear habit. Like I am so consistent. Drives my wife's crazy. That's just how I am. I'm a systems guy. I'm a consistency guy, that kind of stuff. So pretty much I would say 95% of the time, I get up in the morning, I let the dog out, pad around a little bit, and then I usually meditate right after that time. And if I can't get to it in the morning because I got to get kids to school or something like that, then it'll be in the afternoon, occasionally the evening, but morning is my time right after I get up.
All right. You'll have to look into this just because, again, I'm taking a huge assumption here that you're a driven personality type, which is
no.
So there is the school of thought that you should meditate with your eyes open if you're a driven, because we seek safety, and meditating with your eyes closed puts you in a realm of non-safety and never really allows you to kind of turn off that kind of central governor. So just kind of something to throw out there to maybe pique your interest if you haven't read any about that.
I haven't. Does Sam Harris talk about that, or?
Sam Harris, and I'm trying to, as I was talking, I'm trying to think of who I was listening to. I'll pull it up. I'll put it in the show notes for everybody else, and I'll get it to you as well. It was a PhD, double PhD in psychology and maybe biology. I'll get it. Yeah, enough wasting time.
Well, you could make an argument for that, as far as neurological connections to the, the thalamus and everything else. Your vision, your eye is basically an outpocket in your diencephalon. So it's a direct connection to the brain. So that's not really surprising.
Yeah. And it was just interesting to me because I was like, so I've toyed around this a little bit, and it feels a little awkward to just sit there looking at the wall. You're like, am I meditating? Or just staring off into space? So, but maybe they're both the same thing. Last question. And then I want to get a couple little just tidbits on like where people can like take classes and hear more from you guys. What's this about a rum distillery?
Sean and I have this constant discussion about getting a boat and then going to Mexico and opening a rum distillery. That's
you just said that you're not retiring to the Caribbean anytime soon. That's
we talk. It doesn't mean I'm retired. It just means we're podcasting from a boat.
There you go.
While we're fishing. No, it's kind of a joke. Ever since George Clooney, had his boutique tequila distillery, that kind of gave Sean the idea. So we started kind of tossing around the idea. So it'd be kind of fun to do that as far as that goes. So it's just more of a joke thing than everything else. But yeah, we always talk about, the payments on the yacht and things like that. So
the driven personality comes through like, this is how much money we have to make this happen. Well, I know you have the Gait Masterclass. You guys do online continuing education through online CE. You have a blog, you have a podcast. Am I missing anything on tons of offerings for people to learn a lot more? Anything else you want to add in there?
You can go to thegateguys.com where we post relatively frequently as far as that goes. Instagram, not really so much on Twitter. Facebook, obviously, things like that. If you go to our YouTube channel, we got like hundreds of videos there that are free. You can just go and go in and, it's just the Gait Guys. And you could look through a ton of that information. Obviously, they started pulling, I think, some of them down, but we got hundreds of podcasts on iTunes as well. And if you go back into some of the old stuff, when Sean and I first started, we had the Manual Medicine Advisor, which was our first podcast, which, oh my gosh, I can't believe some of the stuff we said and we actually put out there, but it was pretty hilarious. Probably stuff that would be incriminating these days, the way things are. But we were pretty opinionated and pretty strong and really not too unbold about it. Those are the big places. We've got a Vimeo channel where we do our Gait Masterclass. As far as that goes, we really encourage people to just join Patreon. I think, I'm not sure what level, you'd have to ask Sean. I think it's at the $20 level or something like that. You get the masterclass every month. You get extra bonus material in addition to that, as well as, early access to podcasts and stuff like that. Other than that, I think that's a lot of it. If you go to my needling website, which hasn't been updated in a bit, it's allthingsneedling.com or rehabchalktalk.com. That's probably the better one to go to, Rehab Chalk Talk. I've got a bunch of articles on there. Joy, my admin person, posts a lot of my dry needling seminars and acupuncture stuff, which always has a huge gait slant because that's my thing. That stuff is posted there. We haven't really done too much live stuff as far as that goes. It's not that we're opposed to it. Now things are like really weird with travel, with COVID and all that stuff. Certainly not opposed to that. We're actually speaking for the Canadian Podorthic Association coming up here in April. So basically we do a video and then we do a Q&A with Tom Michaud and a couple other people. That should be a fun time. Up in there. You never know where those things are going to go, some of the questions you get. So it's always pretty interesting as far as that. I did this thing for Newton, just as a quick aside, a while ago as a running conference. And Frank Shorter, I don't know if you know Frank Shorter, but pretty famous runner. Anyway, Frank Shorter had really long hair at the time. He looked just like Alice Cooper. And I couldn't stop looking at him because I kept thinking it was Alice Cooper sitting up there next to me. I'm kind of a music guy. I'm a bass player and a musician and, listen to basically older music that I probably shouldn't be listening to. So
it sounds like we have a lot in common. And one of them is being like ADHD hobbyists, which drives my wife insane because she's always like, you have all these things that you're doing professionally. Why do you still need to play guitar and trail run? And it's like, well, that's kind of how you're built. So I love it. Anybody that I've ever talked to, maybe I just draw that on the show. We all need to start a podcast called the Polymath Podcast, and we'll just all get on here and talk about all these weird things and go off on tangents and
sort of like Tim Ferriss.
Yeah, and it'll be cathartic because we'll all be like, man, we got to talk about all the stuff we want to talk about and not have to pick one vein at a time.
That's a great idea.
But yeah, man, this has been awesome. I could literally, I'll say this to vouch for what you just said in the educational offerings. I've been a student of all the free things. So I have to say thank you, first of all, for years. Like I said, I started chiro school in 2009. And it was early on that I started looking at you guys' stuff and following you. And that's how I started. We started working with Extreme Footworks and Sean and all this stuff. So thank you so much for what you do and what it's provided for me in terms of perspective and pushing myself. So I'd love to have you and Sean back on the show, maybe together again, and ask more questions, because this is a never ending conversation, because we're always learning and conversation changes as maybe I get smarter, maybe I get dumber. I don't know which one it is based on if the knowledge is going in or out. So I think it's a little bit of both, but
as long as we keep learning, that's the bottom line.
That's right, man. Well, thank you so much. And it's been a pleasure.
Yeah. Thanks so much for inviting me. We don't do many podcasts and stuff like that. Partly just because of scheduling reasons and stuff like that. We're both pretty busy with our clinics and things like that. Not that that's an excuse. It's just more of a, and a lot of people they want to talk about, I don't know, they don't want to talk about stuff that we want to talk about as far as like feet or stuff like that. People kind of find that boring, and that's okay. There's enough of us out there that are kind of geeky about it that, we can get together and do that. So
And there's a reason that it's become so popular to talk about feet. Like, it is a huge deal, right? And it's anything that's I mean, it's like breathing, right? Like, things come back around cyclically. We're in this time frame of like, it's very important. And I think you're at the tip of the spear on this stuff. So more people need to be driven towards what you guys are doing. So again, thank you.
Thanks. Yeah. We
appreciate
it. Appreciate the offer again.
Yeah. I can't thank Dr. Ivo enough for being on the show. I hope you guys enjoyed. As always, if you haven't, please subscribe. If you would be so kind, go leave us a review. 5 stars appreciated, right? It's a little something in there. Let us know how we're doing. You can always reach out to me via social media. Facebook, Instagram is the best, at Dr. Beau Beard. You can email me, drbeaubeard@gmail.com. Check out the YouTube channel. We also have videos of this podcast for listening. If you're watching, you can go over to Apple Podcasts or Spotify or Stitcher. I'll see you guys next time.